Hello, well, clinicians. This is Nasseh, and I'm back here again with Dr. Eleni Gagari, the diplomat of American Board of Oral Medicine and Director of Oral Medicine Clinic in the Dermatology Program at the University of Athens School of Medicine. Elena, thank you again for joining me.
Thank you for having me.
We just had a little tutorial earlier about an actinomycosis case, and hopefully that was, if you haven't seen that, you can go and view that one as well. And basically, we arrived at, at a point where we had to make a diagnosis about a periapical lesion. And that really leads to the real question of a differential diagnosis in periapical lesions, periapical pathology, stuff that, we as endodontists and general dentists who do root canal therapy end up dealing with every day. So let's go to your presentation, which you have kindly put together for us, which is basically titled,
Is this an endo problem? The differential diagnosis of periapical pathology. That was a great case, the actinomycosis case, and actinomycosis as periapical pathology illustrates the point very well of, yes, we have a periapical lucency, but is there any case where this could be something different than a periapical lesion? Statistically speaking, there's not a lot of information, but whatever we know points to the effect that about 100% of the 90%, 99% of the time, you know that it's a periapical pathology, it's diagnosed correctly and treated endodontically or with the appropriate indicated manner. In that 1% of the time, though, you should bear in mind that those cases that get missed or misdiagnosed have a danger element to them. About 30% of those cases that are not classic periapical pathology could be malignancy. And so I think it's a good idea to take a journey down that lane and see what it could be. So let's start with the good news first, the benign lesions. All right, here you have some periapical lucencies, as you can see. They look pretty standard, and they should really be evaluated by an endodontist. The key here is that the teeth are vital. And so you have periapical lucencies and tooth vitality. I think for anybody who knows this field, the other element that they're going to notice is that there are multiple lesions. So vital teeth, periapical lucencies, but teeth are vital. And this points to periapical cemental dysplasia, a benign entity. And the teeth should remain untouched because this is what happens later on. They calcify the lucencies and they become opaque. And yes, if you do need to do an endo treatment on these, it's no joke. I think it's a difficult endo treatment. If one of these teeth gets abscessed or is necrosed, it's a difficult endo treatment. However, for the sake of this, there's no need for an endodontic treatment, just recognition of the disease entity. Periapical cemental dysplasia.
Now we see these, with the Gagari, we see these very kind of on a routine basis here, and I think that most of the time you find them in females in their mid kind of lifetime, in the lower mandible, and in the African American community it's actually more common.
That's
and
correct.
A lot of times when we see it in the early stages, just the periapical radiolucency, it does get mistaken for a lesion. And the key, as you mentioned yourself, is to do your pulp vitality testing, because you cannot have pulp that is vital and a periapical lesion at the same time, or at least it's completely normal and vital. I mean, sometimes in irreversible pulpitis, you can end up having a little bit of periapical radiolucency, but certainly nothing of that size.
I think it's the endodontist ABC here that save you. So if the teeth are vital and you see multiple lesions with no cause for them, then you really should put that in your differential diagnosis.
Absolutely.
Here we have another case, and it's a lucency, but notice it's a little bit off-center. That's not to say you can't have a periapical lucency. That's periapical pathology off the center, or an endoperio problem here. This one ended up being a central giant cell granuloma, which is a benign lesion. It can be expansile and cause problems for the patient. Certainly, if you endotreat that tooth, the lesion's not going to go away. And you may end up with a situation where the tooth is endodontically treated and the lesion keeps growing. And oftentimes it will expand the bone. So what would happen if that's the case? One of the things you need to remember is if you do an endo treatment, and it's done to the best of your ability, but the problem doesn't get taken care of, then you need to consider other things such as this one. Usually it's larger. Usually it's in the corner of the jaw, but that's not to say that it can't go in the apical area.
And you can see that there's a little bit of resorption of the adjacent
Yeah, that's a
root
good point.
as well. You don't normally see that kinds of resorption, lateral resorption with periapical lesions that are granulomas. Sometimes you can, of course, and I guess that's really a key thing that, there are exceptions to every rule, right? And
you have to be observant, and that's a good observation. And in a lot of the periapical pathology that you'll see here, the situation with the lamina dura is key. You need to be observant around the lamina dura for signs of infection as opposed to signs of other type of processes.
Yeah. Again, it goes back to pulp vitality testing.
Yes.
Key thing.
Yes.
When you see something like that with a vital pulp, I guess as a general dentist or something like that, you probably want to refer it out to have a biopsy.
Do you have a biopsy on this one? Yes. I think, unfortunately, it sounds alarming, but that's all that remains. It's an intraosseous biopsy in these cases.
Yeah.
Now, this is not likely to be mistaken for a single periapical lesion, but it has some of the characteristics that I want to point out. You could potentially have all the teeth involved dead and creating a huge periapical cyst of inflammatory origin. However, notice the displacement of the teeth.
Yeah.
And the expansion. So even if it's a smaller lesion, but you see the expansile nature of it, that's not something that's very common with periapical inflammation.
Exactly.
So the expansile pushing of the roots apart, that's a telltale sign that I want people to remember.
It's fairly aggressive.
And this one is a benign lesion. However, it does damage to the patient. It's a central ossifying fibroma. It's seen in young patients. It's seen in women in the 4th decade. Benign, biologically aggressive. The patient may well end up with a resection because it enlarges to such a big size.
That's right.
This one, I think this one you recognize right off the bat when you saw it, right? For anybody used to looking at radiographs, there is a scalloped border here. However, it is periapically located. The key is the way the lucency is formed, and that's a simple bone cyst, otherwise known as traumatic bone cyst. And here we have trauma at some point in the patient's mouth that created it. And if you go into it, you find an empty bone cavity.
It's an empty space.
So again, notice that the periphery of the lesion is pushing the lamina dura, but actually you may have resorption of teeth, but it's when the lesion has gotten to be huge. Over here you see that the roots are still pretty much maintained. And one of the nice things about this lesion is that it's an empty cavity. If you go curetted, you can have very good bone formation in the area. You don't need to do anything much, at least in the sizable lesions. If it's a very large lesion, you probably need to do some bone conductive approach.
Yeah, I found a lot of things that are well confined, such as this one. If you're just going to make it bleed, you get enough growth factors and platelet-derived growth factors that are in the blood itself that you're going to end up getting just,
Well, think about whether you'd want a piece of your jaw missing for something as benign as this. I certainly wouldn't want it. I would want it. I would want the conservative way for this one, knowing the nature of it.
That's true.
Now, in the weird and wonderful category, you can't really possibly have a periapical lucency on every tooth in the oral cavity. Well, potentially, I guess you could, but there has to be a reason for it.
That's right.
And so, in this case, we have periapical lucencies, and we also have a singular finding in all 4 quadrants, complete loss of lamina dura. That is a diagnostic sign of secondary hyperparathyroidism, which can result from renal insufficiency or a pituitary tumor. And seeing as calcium and phosphate, there's an imbalance there. We have resorption of the lamina dura and the appearance of these very thin-looking roots. I can't quite put it in any other way, but the effect is being generated by the loss of lamina dura, not resorption, but loss of lamina dura. So the key point I want you to take home from this one is that if you see it on every possible tooth, it's a systemic disease, and that's really uncommon, but that's the way it is.
That's a great point because, we get these localized lesions,
Mm-hmm.
but it's always important, general dentists always have
Correct.
full mouth radiographs, so they
Mm-hmm.
can always, use contralateral side
Yeah.
to check and see what's going on.
I think it makes the argument for comprehensive approach
Comprehensive,
radiographically for the patient, so you know
That's true.
exactly where all the lesions are.
Absolutely.
Now, this is more of a tricky situation. You have here a lucency, and it could represent an endoperio problem very well. You see something that involves the furcation of the tooth. It's poorly defined, poorly demarcated. And that's one of the dangers in the area. This is a case of osteosarcoma, a very malignant tumor of bone that does this. First off, it destroys bone, and oftentimes in the area of the lamina dura. So first you see the lucency, then you see the opacity. This could very well be treated as periodontal disease or endodontic, also an endodontic problem. It will not respond. And again, here we go into the situation of whether we need to sit on it or do something about it. The tooth may very well be vital here.
Yeah.
If you get extensive lesions and they float in it, they end up necrosing, but it could still be vital. Here's another case that I think makes the point of how deceptive this malignancy can be. Another periapical radiolucency in a different location, and loss of lamina dura because the tumor does invade lamina dura and causes before it does that, it causes a widening of the lamina dura that's asymmetrical, and then it causes a resorption, and we have the lucency effect. Another case of osteosarcoma. This is not a live patient radiograph, as you can tell. This is a resection specimen. It shows you and provides for you a sequence of what happens to osteosarcoma if you leave it alone, and you can see the bone apposition next to the bone resorption. You can see how wide the margins of the resection are and how serious the disease is. Basically, when you have this size of a tumor, you cannot be sure that it has not infiltrated way beyond what you see in this radiograph. They have poor prognosis. People usually in their mid-40s are the victims of this. Fortunately, it's not common.
Yeah, the sun reappearance also radiographically is kind of a telltale sign.
But many cases are diagnosed by dentists or people in our profession and with our specialties because that's where it appears, in the jaw. So this is another case. Notice that the radiolucency here has a scooped out look. Again, it mimics endoperio disease. The teeth here early on are vital, later on may be non-vital, and you can actually have bone resorption that allows for the root of the tooth to be seen in the oral cavity later on. If you treat this tooth endodontically, the lesion is not going to go away. And again, the principle of multiple lesions in other areas, are they present? Because that's a case of Langerhans cell disease, a malignancy of histiocytes that may affect younger patients at different stages in life. Oftentimes it localizes in the apex, and there's a variant of the disease called eosinophilic granuloma because of the presence of eosinophils in that area. Again, if you have a small one lesion, people argue that you can do pretty much what you did before. You can do a surgical debridement around the tooth and leave it at that. Some people think it should be a good idea to do chemotherapy or a radiation treatment. But if you just have the one lesion, then probably you should debride it and have the patient on follow-up. They might develop other lesions, or they might have that single lesion. And that's the adult form of Langerhans cell disease, which has a better course, milder course than the childhood form and some others. So if people have this, at least they're lucky in their bad luck in that it's treatable, so long as it's recognized early on. Now, this doesn't quite look like periapical disease, does it?
No, it doesn't look good at all.
Yet, unless you know that it exists, you can't really recognize it. Here, the tip-off radiographically is the moth-eaten appearance. You see bone that looks like a fabric that has been torn apart, eaten by moths, and that's the hallmark of two things. One is malignancy, and the other is osteomyelitis. So here we have a case of metastatic breast cancer, and metastasis often mimics periapical disease. We can have breast cancer, we can have prostate cancer, thyroid cancer, and these are the most common. GI and renal cell carcinoma go to the mouth, but not as commonly
Not quite commonly.
in the jaws. Mandible being a common site for metastatic lesions in the oral cavity. Having said that, that's a rare type of lesion. However, when people get screened in breast cancer, in the past they didn't used to get screened for the facial bones, and now they do,
Oh,
because it's been recognized that you can have metastasis there.
yeah. One of the more common places is the jaw because of the bone. I mean, the bone is obviously both prostate and the breast cancer cells have markers for the bone, and you find them just metastasize to those areas very commonly. So, what do you have for us there?
Well, sometimes I feel mean with my students, and I have this just to amuse people. When you see all those weird things that we are asked to diagnose in our specialty, and we get used to looking at the zebras, you have to remember that if you hear hoofbeats outside the door, chances are it's a horse, not a zebra. So you'll tell me what it is because you know it. You knew it right off the bat looking at it. So
yeah, we see this quite a bit. It's the nutrient canals basically that are just basically appear radiolucent radiographically in some people in the anterior area.
I have to tell you that I used that radiograph to test residents, and the poor people, having been tortured with weird stuff, only 1 out of 10 recognized it. They knew what it was, but if you show people a lot of strange things,
That's right.
then we have to remember to keep our cool and be able to recognize the garden variety.
So that's a good teaching tool. You ask tough questions and then suddenly throw in a simple
Yeah.
one, and that confuses them.
Yeah, well, it confuses them, but it also teaches you to get back into the basics of what
That's
you
true.
do. This is what you did with a case in actinomycosis. People thought it was trigeminal neuralgia, but you went back to the basics. There is a periapical lesion. Let's treat the periapical lesion. So let's not forget that because we're showing you strange stuff here.
That's true.
And so I want people to look at these two and do radiographs and tell me if it's an endo problem. So we have before and after. You can see the radiolucency before, and you can see that the treatment is pretty adequate, wouldn't you say?
Yeah,
I mean,
yeah, of
the
course.
endo treatment has been done, has been performed adequately. Yet the lesion has increased, the lucency has increased, it has expanded. So at this point, I know a portion of us that would go in and be tempted to do a retreatment. That's not the right approach. The right approach is
To
you've
biopsy
done,
and get an array.
you've
Yeah,
done the right
surgical.
thing. You've done it to the best of your ability, and it's more than adequate. If there's another lesion, remember that strange things can happen, and this is no longer an endo problem. So to recap, lack of the pain you expect associated with a tooth that's necrosing or that has died before. The teeth are vital, and yet they're surrounded by lucencies. That's another key point to think of something else. Multiple lesions, look at the whole area, look at a panoramic radiograph, look at a CBCT, but take a look at the whole patient and just get an idea of what is there in the oral cavity is very important. The lucency, if it feels off to an experienced clinician like you, if it doesn't quite fit the criteria, that feeling has saved more lives than I can tell you from a lot of my contributing clinicians. They will all say, well, it didn't quite feel right, and
Right.
trust that feeling. And finally, if you've done the best to the best of your ability, the endodontic treatment or the perio treatment for that matter, and there's no response, but you think that you've treated the patient very well, well, then it's something else. And there are specialties who do this. There's oral surgery. You need to refer the patient for a biopsy. This is just for the 1% of the unlucky patients that we need to have. Hopefully you won't have them in your practice, but they might show up.
That's right. And you should be prepared. I think doing a biopsy, I mean, anytime you have a refractory lesion that doesn't resolve with adequate endodontic therapy, and you end up, usually the next step would be to do apicoectomy, whether it's an endodontist, an oral surgeon, or somebody who can do apicoectomies adequately. Nowadays, especially with the microsurgical techniques, you'll have very good success rates with apicoectomies. So just doing that extra step of sending out the lesion for biopsy just going to helps know what is going on. There was a very recent article, I think it was last month, in the International Journal of Endodontics or Journal of Endodontics, that was about was showing the incidence of refractory lesions. How many of these cases were actually keratocysts of these of the lesions that were present periapically? And clearly, we know that that requires a certain a more aggressive kind of treatment and also more observation, so due to its recurrence. So I guess the key lessons, as you mentioned yourself, is to do biopsy, to also have recalls and follow-ups on your patients.
That's correct. That's very important.
Anytime you have a tooth with a lesion, periapical lesion, it should respond to endodontic therapy. And if it doesn't, then we need to know why. So I think those are all very important.
In short, don't skimp on what you've been taught in a good endodontics program and in a dental school. It may happen just once in a lifetime, but I think once is enough.
That's true. Especially if it's the person to whom it happens.
Exactly.
That's important.
That's 100% for that person.
That's 100% thing that you will remember forever. But also, I think in terms of diagnostics, just going back to the basics, endodontic diagnosis is fairly simple. As long as people go through the diagnostic in a systematic way,
yes,
you will actually end up getting very accurate answers. As endodontists, we're not supposed to diagnose everything, but we're supposed to diagnose if the problems are odontogenic.
That's correct.
And also, you should also be familiar with all the non-odontogenic possibilities that are out there, so that you can, as you said yourself, that comes with experience. So you actually get a feeling that this just doesn't quite jive. It doesn't make sense.
That's correct. This is in essence triage, and nobody else is going to do the triage but the general dentist and the endodontist in this case. So you certainly are not going to find a physician doing this. And we've been taught how to do it, and we're the experts.
Absolutely. Well, sounds like the police is coming to get us. So thank you so much, Eleni Gagari, for joining me and going through these cases with our viewers. Okay, so for those of you who have any other questions, you can watch these videos and leave a comment on our website, reworldendo.com. Dr. Gagari can be reached also at University of Athens. Again, thank you so much for joining me, and we hope to have you on again so we can do some more cases. This is just the tip of the iceberg, obviously. There's a lot more information out there. These are just some of the potential possibilities that are out there, and I hope everybody pays attention to these. For Reworld Endo, I'm Nasseh, and I was joined also by Dr. Eleni Gagari, Director of the Oral Medicine Program and in the Dermatology Program, University of Athens, and we hope you found this information helpful.
Thank you.